This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. My name is Shauna Strickland. I am the Associate Executive Director for Education at the AARC. I welcome you to today's presentation, Pulmonary Function Testing, Respiratory Care Journal Highlights. Upon completion of this AARC webcast, participants will be able to discuss at least one quality issue related to selecting personnel to work in a pulmonary function lab, identify at least one clinical indication for measuring lung volumes, describe a bronchial challenge test that uses an indirect agent, suggest why using the LLN may be preferable to using percent predicted, and name a new method for COPD screening. I am pleased to welcome Gregg Ruppel. Mr. Ruppel is an adjunct professor in the Pulmonary, Critical Care, and Sleep Medicine Division of the St. Louis University School of Medicine and is currently the chairman of the NBRC Pulmonary Function Examination Committee. He is also co-chair of the Respiratory Care Journal Conference Proceedings. Gregg discloses that he has relationships with Medical Graphics, Gilead Sciences, and Biomedical Systems. Gregg, welcome to the program.
Well, thank you, Shauna. And thank you for having such a large group of interested folks showing up here this afternoon.
Gregg, I'm not sure if you can hear me or not, but it looks like we lost your audio there. Will everyone stay with us for just a second while we get that microphone back to Gregg?
I'm sorry, there it is. Is that better?
Thank you.
Okay. So this is information that was presented at the Pulmonary Function Conference held back in March of 2011 and then published earlier last year in the journal. And so I'll try to go.
Hi, Gregg. It looks like it went out again on us.
Okay. Every time I change the slide, it seems to go out. The question here is, what are these guys doing? And those of you who work in pulmonary diagnostics probably recognize that this is myself and Dr. Paul Enright demonstrating the MIP and MEP maneuver, otherwise known as suck and blow. And so we had a good time at this conference. And I'll continue on and let me know if my voice fades out again. The conference participants are listed here. Paul and I were the co-chairs of this, and as you can see, there's quite a knowledgeable panel of individuals who are involved in the conference itself. And I will basically touch upon the topics that each one of these individuals addressed. And of course there's no way to cover the entirety of what was discussed in each of their 1-hour presentations, but I'll try to highlight those parts of the presentation which are most appropriate for the topics that we're interested in here today. When we set up the conference, we thought that it would be better, rather than just reviewing the state-of-the-art in pulmonary function testing, to actually look at some problems or questions that should be addressed by pulmonary diagnostics. And so you see here a list of the 13 questions that were provided to the presenters. And they are, I'll just read these off, attacking the endemic of DLCO errors in the PFT lab, what is the clinical value of lung volume measurements, what's the best PFT for wheezing patients with normal spirometry, which PFTs best differentiate between COPD phenotypes, children should not be treated like little adults in the PFT lab, what's the role of PFTs to monitor the adverse effects of things like surgery, drug treatments, and radiation, airway resistance, what's it good for, when should exercise testing be done, would you like your mother tested by this technician, and what is the appropriate interpretive strategies to optimize classification. How should the lower limits of normal of the range be defined? And should we keep pushing for a spirometer in every doctor's office? And what might the PFT lab look like in the future? As I said, those are the questions that we gave the participants. And when we look back over the topics and how they were discussed, there were really 4 major themes that popped up. And those were tests and testing, quality issues, the use of predicted values, and then interpretation of pulmonary function tests. And so there was quite a bit of overlap in the presentation. So as I go through each of the individuals' topics, I'll try to show you where those overlaps occurred. Dr. Meredith McCormick talked about the fact that diffusion capacity testing, even though it's been standardized more or less for the last 20 years or so, still is much more variable than most clinicians would like. And the main components of her presentation is that quality control for DLCO testing isn't done routinely. Equipment technologists are still the sources of variability when we compare DLCO measurements done in different labs. And finally, that the repeatability criteria that we currently use may actually be too lenient for most purposes. Dr. McCormick showed some unpublished data from Jensen et al. Showing a group of 125 PFT labs in which about 1/4 of them failed simulator testing when they were being evaluated for a multi-center trial that included DLCO. The good news was, as you can see in the slide presented here, is that by cleaning up some of the problems that were involved in some labs, the number of failed simulation tests dropped to much less than 10% over the course of this particular investigation. So it's apparent that applying careful quality control rules to things like DLCO testing, the quality of the tests can be improved over time. She also talked a little bit about data from her lab, and again, this was a study from a multi-center trial. 33 sites were involved, a large number of participants, and what they showed is that you probably can't read the x-axis here, but where the arrow points to 95%, that's showing that the repeatability of DLCO efforts within the same patient in a single testing was 95% of the time could be within 2 mils of CO per minute per millimeter of mercury, which is significantly better than the current guideline of 3 mils per CO of CO. And they even showed that the 75% of the participants could get within 1 mil of CO. So again, her suggestion was that we may be able to do a lot better than is currently being recommended by the ATS-ERS guidelines. I was given the topic of whether or not lung volumes are useful, and the areas that I tried to touch on were that lung volumes are required when the vital capacity is low, that air trapping and hyperinflation do show response to bronchodilators, and that may be a reason for doing lung volume measurements. And we also discussed briefly whether or not there's an ideal method for doing the measurements, whether or not body box and dilutional techniques can be used interchangeably or not. A lot of the data that was presented at the conference was rather old data, but we felt it was important to bring it up in the context of the types of questions that we were attempting to answer. This is some data from Sean Aaron and colleagues, and they showed way back in 1999 that when the vital capacity was reduced, and you can see that on the x-axis of these graphs, that the probability of restriction went up dramatically. The other thing that they showed was that a normal FVC, that is an FVC up in the 80 to 100% of predicted range, was very seldom associated with a restrictive problem. So we know that a low vital capacity can be due to either obstructive lung disease or restrictive lung disease, but a normal forced vital capacity really tells us a lot about the total lung capacity. It's only when the vital capacity begins to fall that we need to consider whether or not we need to measure lung volumes. And so the suggestion here is that if the vital capacity is abnormal, then lung volumes are likely indicated. In the slide, the graph on the right-hand part of the slide simply shows that that's even more important when we take into account the fact that the individuals may have obstructive lung disease. The lower lines on that graph are folks who had various different degrees of obstruction. Another topic that I touched on briefly was the importance of lung volumes in assessing response to bronchodilators. And this was some data that was fairly new at the time from Dennis O'Donnell's lab in Canada, where they looked at a large number of COPD patients and showed that when they compared response to bronchodilators by gold stage, that things that involved lung volumes showed larger changes than even the garden variety things that we normally think about measuring for bronchodilator response, such as the FEV1 and the FVC. And so you can see highlighted on the slide here in pink are individuals who had a greater than a 10% change in their lung volumes or any other measurement. And the part highlighted in pink shows that the residual volume showed the greatest degree of change of any of the lung function variables listed there, and that the individuals with the worst obstruction, that is the gold 3 and 4 group, had the biggest change. And so I think this is good data supporting the fact that lung volumes may be as useful, if not more useful, for evaluating the response of bronchodilator than even the things that we normally measure, such as the FEV1. So as you can see, reduction in residual volume was really the most predominant change that was observed in this large group of COPD patients. The other variable that I touched on, or the other topic that I touched on, was whether or not gas dilution or plethysmography had any advantage. And this was pretty much a response to a paper published by O'Donnell and colleagues back in 2010, where they looked at the comparison between plethysmography, helium dilution, and CT scanning kind of as a tiebreaker. And what they observed was that there were significant differences between those three methods, especially when you compared plethysmography to CT scanning. Unfortunately, they concluded, erroneously I believe, that plethysmography overestimated lung volume because of the comparison to CT scanning and helium dilution, and therefore may not be the most appropriate way to measure lung volumes. There were a flurry of letters back and forth after this paper was published, and I think several other papers in the last 2 years have popped up in the literature showing that this group of radiologists who thought that plethysmography overestimated lung volume probably didn't take into account the fact that the CT measurements were done with the patient in the supine position, and in only one of the centers did they actually use spirometry to make sure patients were holding their breath at total lung capacity. So the idea that plethysmography is not the gold standard probably doesn't hold a lot of water, and we probably need to, again, consider plethysmography as the gold standard when it comes to measuring lung volumes. Dr. Alan Coates talked a little bit about pediatric testing, and the topics that he covered were coaching, interpretation, scaling of graphics, different variables, and QC criteria for PFT that's done in pediatric laboratories. I think it was interesting that he pointed out some of the discrepancies that those of us who are normally involved with adult testing sometimes overlook when we think about pediatric testing. He made a point of showing us that the aging process, which we know causes the loss of elastic tissue in the lungs and loss of lung recoil, really has not much of a place in pediatric testing because lung elastic recoil is at its max in kids. And therefore, the kids have a higher FEV1 FVC than adults, and as such, the FEV1 itself may be inappropriate for measuring the status of the airways. And so he pointed out that even far back as the 1960s, FEV values such as the FEV 0.75 might be a more appropriate thing to look at when we're concerned about pediatric testing. He also pointed out the much maligned FEF 2575, which we know is quite variable in adults, may have some usefulness in the pediatric population, again because the pediatric subjects tend to empty their lungs very rapidly, and so that they completely exhale their forced vital capacity. And we know that the FEF 2575 is affected by the forced vital capacity. But the fact that the vital capacity is much less variable in pediatric subjects supports the idea that the FEF 2575 may be a more useful parameter. And so Dr. Coates encouraged us to not completely abandon it, particularly in the pediatric population. He also talked a little bit about why the adult quality guidelines may not be entirely appropriate for kids, and he simply showed us that the back extrapolated volume calculation, which is done pretty much automatically by most of our systems, may not be appropriate for kids simply because the adult values, when we talk about individuals with very small vital capacities, may be entirely inappropriate. So a child who has a vital capacity of 1.5 liters, if we consider that 150 milliliters is a reasonable amount for the back extrapolated volume, that would be fully 10% of their lung volume, and so it's probably not appropriate to apply these same adult factors to pediatric subjects. Again, stressing the need for better and more developed guidelines for testing in pediatric labs. Dr. David Kaminsky addressed the topic of airway resistance and how it works in conjunction with spirometry in the evaluation of individuals who have obstructive lung disease. He concentrated on comparing and contrasting airway resistance, specific airway conductance, and specific airway resistance, all of which are used quite widely around the world for evaluating bronchodilator and bronchial challenge responses. And he spoke also briefly about some of the other techniques which are available but are not widely used, at least not in the U.S., and those include forced oscillation and interrupter-type resistance devices, which he felt were not quite ready for prime time, but are quite useful in the clinical research areas. David pointed out for all of us that the airway conductance is very sensitive to small increases in the central airway, but not to small increases in the peripheral airway. And I think the top part of the slide here from Peter Macklin's paper back in 1983 is a good illustration of why that's the case, because of the huge cross-sectional area of the small airways. That doesn't, however, mean that conductance is not very useful, simply because it's more sensitive to the bigger airways. And as the bottom part of the slide here shows, specific conductance is actually sensitive to the entire airway, and when the small airways become heavily involved, it too changes, unlike the FEV1, which generally is felt to be sensitive to airway narrowing upstream of whatever part of the airway is actually limiting flow. And we know that in individuals with obstructive airways disease, we see changes in both specific conductance and FEV1, but not always in the same proportions. And so Dr. Kaminsky's contention was that these two tests of airway function measure different things, and that they are largely complementary, not that we should be using one instead of the other. He also pointed out the information that was contained in a paper done some years ago, showing that in patients who had bronchodilator studies, about 80% of those individuals showed changes in the FEV1 and FVC, as we all have come to expect, but that about 15% of the individuals who had a response to bronchodilator had that response not just in the airway resistance and the spirometry measurements, but in airway resistance measurements as well. And so things like the thoracic gas volume and isovolume flow curves, along with specific airway conductance, also can be very useful for assessing the response not only from bronchodilators, but in bronchial challenge as well. Dr. Kaminsky also kind of summarized what he considered the important aspects of resistance measurements, and again, those are just highlighted in this graph that you see, or table that you see in front of you. Spirometry, that is the FEV1, is well standardized with a lot of good reference equations, whereas body plethysmography is not so well standardized, but that both of them have fairly well established cutoffs for bronchodilator and bronchoconstrictor response, and that they do offer complementary information when we're assessing patients who have airway obstruction. Dr. Bohdin Pacherko from the Cleveland Clinic tried to enlighten us on when exercise testing is indicated and whether or not we should be using full cardiopulmonary exercise testing or just the 6-minute walk test. And his contention was that those two things are not interchangeable. There's still a lot of confusion regarding which is the best test for determining exercise capacity. And even though the 6-minute walk test has become very popular, he held that it's not interchangeable with the CPET. The max oxygen consumption, or max feed-out O2, is still the gold standard for most exercise testing, and especially for specialized indications like patients who are having thoracic resection, heart transplantation, etc. He also pointed out that there are a number of parameters, such as the ventilatory equivalent for CO2 and the heart rate recovery parameter, that are very useful for specific patients, such as those with congestive heart failure. He also highlighted a few portable devices that may be useful in the future when we begin to do exercise testing in a broader range of environments. He also pointed out something that I consider fairly important, and that is that the measurement of oxygen saturation by pulse oximetry has become extremely widespread, so much so that we don't very often measure arterial oxygen saturation the way we used to many years ago. And this is some data from the Cleveland Clinic showing that there are quite a few cases where we get false positive results when we compare pulse oximetry and arterial oxygen saturation, and a few false negative cases as well, as shown in the lower right-hand quadrant of this four-quadrant diagram. So he was very interested in the fact that we still place a lot of emphasis on pulse oximetry in all different types of testing environments, but that we need to be concerned about those false positives and false negatives when we're making diagnostic decisions based on the results of pulse oximetry. Jeff Haynes talked about the technologist as an important part of the testing regimen in most PFT labs, and so he tried to take a little bit different approach and spoke to us about how to select individuals to function as pulmonary diagnosticians, and to look at some different ways of evaluating what might be important characteristics for people who are not just respiratory therapists, but who are involved in pulmonary diagnostics. And so he showed us a number of different tools that stressed things like motivation and feedback, and how those come into play in the individual who is working in the diagnostic lab. So this is just one of the tools that he showed that allows someone who might be considering hiring someone in a lab to evaluate not only their knowledge of pulmonary function and pulmonary physiology, but their motivation and their conscientiousness and some of the other important characteristics that allow people to perform tests where the patient has to be encouraged to cooperate. Jeff also showed some slides that indicated that the way we normally think of hiring people into a particular job in the hospital may not be the best possible way, and he showed us some data here supporting the fact that interviews, job experience, and even education may not be as predictive of quality on the job as things like cognitive aptitude tests. That is, the ability to do critical thinking and to learn when the individual is put into a new situation. And so he really kind of broadened out the scope of what we normally think of in terms of getting people into a pulmonary diagnostics position by showing us that there were some other new and different ways of evaluating candidates for these types of jobs. I thought it was pretty interesting that he summarized by telling us that the traits that we should look for are things like cognitive aptitude, conscientiousness, and critical thinking skills. And so he pretty much told us that the answer to the question, would you like your mother tested by this particular technologist, can be addressed by making sure that the people with the appropriate cognitive aptitude, conscientiousness, critical thinking skills are the ones that we have functioning in our laboratories. The other quality issue that was addressed during the course of the conference had to do with the use of spirometry, not so much in pulmonary function labs, but in other venues, particularly in physician's office. And those of you who have looked through the literature in the last few years probably know that Dr. Paul Enright has written a number of editorials suggesting that spirometry, the gold standard for diagnosing obstructive lung disease, is underutilized, and that performing it in physicians' offices, although that seems to be a very valid idea, may not work as well as we had once thought it would. And his assumption was that respiratory therapists who are well trained and knowledgeable about spirometry probably have a leg up on others in terms of providing access to good quality pre- and post-bronchodilator spirometry, particularly as it applies to diagnosing obstructive lung disease. And he shared some information. This is data from a large Veterans Administration study showing just how often subjects or patients in the VA system got spirometry performed to confirm that they had COPD. And the numbers up there are some of the different VA locations around the United States, and you can see that the best of those, only about 45% of the patients got spirometry, and in the worst of the quintiles, only 23% got spirometry. So, and there's other data in the literature that supports this as well, that tell us that, you know, spirometry, even though it's the gold standard for diagnosing obstruction, doesn't get used nearly as much as it should. He also shared some information that's well documented in the literature also, and that is that in spite of a lot of effort to implement spirometry in primary care practice and in physician's office, many of these studies spending millions of dollars to attempt to do this, that there are big differences in the spirometry that would be done in the general practitioner's office versus what's done in a pulmonary function lab, like most of you are familiar with in hospitals. And so his conclusion was to answer the question, should we keep pushing for a spirometer in every doctor's office, was no. And again, I'm simply stating that this was his opinion, but he offered some rather unusual guidance to try to make this more realistic, and that is things like don't refill COPD inhaler prescriptions without spirometry being used to confirm that they do have obstruction. Don't pay for poor quality spirometry tests. And then he also went as far as to say it might be useful to provide primary care providers with something even simpler than spirometers, or with pocket spirometers, so that they could look for individuals who are at risk for COPD. And then if those individuals could be identified, that they could be then sent to a pulmonary function laboratory where good quality pre- and post-bronchodilator spirometry was available. So this is a little bit controversial, but I don't think it should be anything that we're hesitant to talk about. There have been a couple of papers published since our conference back in 2011 showing the usefulness of things like peak flow meters for doing a very gross type of screening in individuals who are at risk for COPD. And those were done by using peak flow in conjunction with the 5-question questionnaire that's widely used for screening individuals for risk factors. Was found that yes, in fact, you could eliminate some folks who had risk factors but weren't actually candidates for spirometry. And so even though the data is just beginning to show up in the literature, something as simple as a nomogram like the one you see provided here could be used for something like peak flow, where if an individual who has risk factors for COPD blows into the peak flow meter and they fall in the green shaded area, regardless of their age or gender, they would probably be unlikely to have a reduced FEV1, whereas someone who had a peak flow that fell into the red portion of the nomogram could then be referred for good quality pre- and post-bronchodilator spirometry to confirm or refute the diagnosis of COPD. So I think this is something to keep your eye out for as we go forward, and we may see additional types of screening protocols developed in the future that give us a better handle on finding all of those individuals who we know have COPD but that haven't been correctly diagnosed or who have been misclassified somehow. Switching over to predictives and interpretation, there were several presenters who address these issues, and so you'll see a couple of names listed here. Both Meredith McCormick and Dr. Al Miller talked about the fact that most of the reference equations for lung volumes and DLCO date back many, many years and are not well established, and that what we really need are NHANES-like standardization of predicteds that would be useful. And again, that was something that the entire group concluded that is extremely important. Now, whether or not that's going to happen within our lifetime, I'm not terribly sure, but the need for more and better predicteds for both lung volumes and DLCO, particularly for DLCO, is a much needed thing that should be done going forward. This is doubly true for the pediatric population and for the elderly. And again, that was kind of a consensus from Dr. Coates and Dr. Miller. And this is just a list from the 1991 publication of the ATS showing some of the widely used DLCO equations. And you can see the most recent of these is 1990. So again, I wasn't being facetious when I said most of these are more than 20 years old. There's been a few papers published recently showing that the Miller predicteds, the 1983 Miller predicteds, and again, this is Dr. Al Miller's data that he produced, do probably have the most wide-ranging usefulness. And there's been at least one paper showing that using those predicteds for DLCO were better able to correspond with individuals who had severe lung disease and were in danger of decreased survival because of their lung disease. So the bottom line here is that the choice of DLCO reference equations makes a difference, and that we really do need update of the predicted equations. Dr. Bruce Culver went forward and talked a little bit about something that you probably have heard about, and that is the lower limit of normal being used for determining whether or not disease is present. And Dr. Culver made a point of emphasizing that just because someone's pulmonary function variable falls below the lower limit of normal doesn't necessarily mean that they have disease. So it was kind of a two-pronged argument in that we need to use lower limits of normal rather than simple percents of predicted because they tend to be statistically more valid. But we need to be careful that just because someone is at or near their lower limit of normal doesn't necessarily mean that they have disease. And so, again, if you keep in mind that the lower limit of normal is really the lowest fifth percentile of a normal healthy individuals, we simply assume that those folks that fall that far below the mean or the average are significantly different. But again, they're really false positives. They're really normal, healthy folks that have a value that's well below the mean. Dr. Culver also showed us some information from the Global Lungs Initiative, which he was involved in. And I'll show you another slide here in just a moment with some of that information. And he talked a bit about using what's referred to in statistics as the LMS modeling approach as a better way to come up with the predicted values that we all need in the pulmonary function lab. The LMS approach was popularized a few years back by Sanja Stanojevic and Janet Stocks and their co-workers in Great Britain. And what they did is they took this statistical method, LMS standing for lambda mu sigma, which included not only the typical variables that are used to generate regression equations for calculating predicteds, but also took things like the coefficient of variation and how skewed the data was. And this is the statistical method that's widely used for growth charts in children. And they applied it to the NHANES 3 data and showed that by applying this statistical method, they could eliminate the need for separate equations for children, adolescents, and adults and come up with a smooth curve that could be used to describe the changes in lung function that occurred across all ages. And so this particular method generates what we now refer to as all-age predictives, and has been used in a much larger study. And so Dr. Culver showed us some information, and this is was unpublished at the time, but has recently been published in the European Respiratory Journal just a few months ago. And this is the Global Lungs Initiative predicted set. Now this is just for spirometry, and the graph that you see in front of you shows the FEV1, again, across all ages for a large number of different ethnic groups: Caucasians, African Americans, and Orientals. This is an older graph that was published early on, and the Oriental lines have now been subdivided further so that we have Northern Asian and Southern Asian groups that can be used widely. And this data is based on a large number of subjects, about 72,000 spirometries done in all these different ethnic groups from a large number of studies around the world. And you should be prepared to think about utilizing the ERS Global Lungs Initiative predicted values for your equipment in your lab, not necessarily right away, but sometime in the near future. Again, several different individuals talked about the fact that our interpretive strategy, such as the one that's promulgated by the American Thoracic Society, is probably a little bit too simplistic for really stringent use in the pulmonary function lab. And Dr. Steve Salzman spent some time trying to illuminate the fact that bronchodilator responsiveness is not as useful as we once thought, simply because it's not well standardized and may show changes in the same subjects when it's repeated over and over again. You may recognize this graph as the interpretive algorithm that was published in 2005 by the ATS-ERS committee. You should note that all of the variables up there don't use percent of predicted, but they do use the lower limit of normal. But as Dr. Al Miller pointed out, the number of buckets at the bottom there are probably not enough to really help us make the types of diagnostic decisions or diagnostic clinical decisions that should be part and parcel of the data coming out of the pulmonary function lab. So again, this is a start in one direction by using the vital capacity and then lung volumes and then DLCO to try to come up with a diagnosis. But the group agreed that this could be refined probably a lot more, particularly in those individuals that have a low DLCO. It's probably not illustrative enough of the types of disorders that we commonly run into. So although this is a good starting point, it's not the end of the story. Dr. Bill Bussey and Dr. Salzman also talked a little bit about cluster analysis, and I'll show an example of that here in a moment. But Dr. Bussey, his topic was what's the best test for somebody who's wheezing but has normal spirometry. And so he basically addressed the whole idea of what type of broncho challenge study should be used, and is there a way to help us decide what might be most appropriate for the patients that show up in our laboratory. One of the slides that really caught my attention was the one that you see before you here. And again, this is one from Dr. Bill Bussey. And I think it's an interesting slide because I think he's really put together the physiology and what we know about airway hyperresponsiveness. We know that AHR, or airway hyperresponsiveness, is the key finding in asthma, but we know that there's a whole broad range of how that presents itself. And Dr. Bussey pointed out, or at least categorized, two different types of airway hyperresponsiveness, variable and persistent. And his feeling, and I think this is probably an appropriate way to look at these things, was that the variable aspect of airway hyperresponsiveness was largely due to the things that you see at the upper part of the slides, things like inflammation, whether caused by an infection or an allergen or something that the subject gets exposed to in their environment. But that type of airway hyperresponsiveness is variable. The other side of the coin would be what you see at the bottom of the slide, which he could call persistent changes in the airway, things like subendothelial thickening, smooth muscle hypertrophy, changes in the matrix of the airway wall itself, that includes vascular changes as well. All of those things that we sometimes lump together as airway remodeling. And his way of looking at this was that this is the persistent part of changes in the airway. What makes this kind of come together is that he suggested that the variable component was more likely to be uncovered by using an indirect type of bronchial challenge, whereas the persistent components were more likely to be uncovered using a direct type of challenge. And he presented some data from Dr. Sandra Anderson to kind of illustrate whether or not we might want to use something like methacholine versus mannitol, mannitol being an indirect type of challenge and methacholine being the classical direct type of challenge. And this is some data in individuals who had a number of different tests done, including both mannitol and methacholine challenge, as well as exercise testing. And I think you can tell simply by looking at the quadrants in this diagram that there's quite a bit of scatter. There is a weak relationship, as pointed out by the R of 0.41, between individuals who have a change in their airway function when they're exposed to methacholine versus being exposed to mannitol. Again, the blue dots represent individuals who had a little or no response to exercise versus individuals who had a pronounced response to exercise. And you can see that whether you use methacholine or mannitol, you may pick up one or the other. What Dr. Bussey was careful to point out was this variability suggests that perhaps the way we need to think about diagnosing what's causing the airway hyperresponsiveness is to be prepared to use more than one challenge agent, maybe exercise or mannitol in some instances versus methacholine in other instances. And so he went on to provide us with some information from Donald Cockcroft's lab, where Cockcroft compared the direct and indirect types of challenges. And what he kind of shows in the table here is that the direct challenges really do work to tell us about the muscle function, airway caliber, but the indirect challenges really have their high point in pointing out who has inflammation. So again, the type of dose that's needed, whether there's a dose limiting effect, and then the sensitivity and specificity is significantly different between the two types of challenges. So I think most of this can be summarized fairly well simply by looking at the bottom line there. We can think in diagnostic terms of the direct challenge, again, something like methacholine, being used to rule out airway hyperresponsiveness, whereas the indirect challenges, exercise, hypertonic saline, mannitol, those types of things, might be better used to rule in the type of airway hyperresponsiveness that we associate with exercise-induced bronchospasm. And again, this is some data that Dr. Bussey showed us, simply showing how cluster analysis can be used to show that the various phenotypes that show up in individuals with asthma can be pretty well segregated when we apply the types of analyses that's shown here. And so this is a large ongoing study that Dr. Bussey's lab's involved in, and you can see that in addition to the demographic information at the top, we have the typical baseline lung function and then maximal lung function after bronchodilator, along with atopy determined via skin test. And you can see that across those clusters of different degrees of airway obstruction and responsiveness, there's pretty significant differences. In fact, the differences are significant in all of the categories, save race. Except for body mass index. And so I think this is the type of analysis that is useful and will probably stand us in good stead as we look to the future in terms of what pulmonary diagnostics can offer. There were quite a few things that the group discussed, and one of the things that came out in multiple different presentations was that the pretest probability of disease is important. And Dr. Miller pointed out that this is something that the pulmonary function lab should be responsible for. In other words, the history and physical findings that we record in the patient at the time they're being tested are very important, and that's something that should be included as part of the report to the individual trying to interpret the numbers. Dr. Hanituk spent a bit of time talking about the role of PFTs in decision making, and this was basically a review of when pulmonary function tests are indicated and when there are situations where they may not be indicated. And so we know that if your patient's being worked up for thoracic surgery, particularly for lung resection, that pulmonary function tests are a very important part of that. However, poor lung function is probably not a contraindication for other types of surgery. And I think this has come to the fore in the last few months. If you've been paying attention to the local news, you may have heard him talk about the American Board of Internal Medicine's initiative Choosing Wisely, where a lot of different professional physician groups have come out with the types of tests that aren't necessary for different types of procedures. And again, one of those recommendations includes things like were discussed here. What's important for making therapeutic decisions and what things are not important. So I think we're going to see more of this type of information in relationship to the types of tests that we do in the pulmonary function lab now and in the immediate future. Again, further study of the patterns of pulmonary function are needed. If there was one overreaching topic that came out of the conference, this was it, that we need to be able to relate physiologic findings to outcomes. And that's something that falls on not only the physician interpreter, but is part and parcel of the individuals performing the test as well, is to be able to make sure that the physiologic data can somehow be related to outcomes. And that probably has its most important implementation in things like setting severity thresholds. You probably are aware that the severity thresholds that we have for COPD are arbitrary. They haven't ever been validated, so we say that someone whose FEV1 is less than 50% of predicted has severe COPD, but again, that's an arbitrary number that needs validation, and that's one of the things that pulmonary function testing can provide. So the group felt that evidence-based medicine will benefit from providing physiologic data that can be related to outcomes. Last but not least, Dr. Neil McIntyre spent a bit of time talking about what he considered things to watch for in the future. And again, there was quite a bit of overlap with some of the other presentations. But the thing that Dr. McIntyre stressed for most of his presentation is that more and better training for both technologists and physicians will probably be the thing that makes pulmonary function labs important and necessary for the foreseeable future. He also reiterated the fact that we need to do a better job in terms of making sure that the data that's produced in our labs that is good data, and that comes through good quality assurance. And that was really something that the entire group stressed. He also talked a little bit about some of the newer technologies that might be something to watch for in the future, and that included things like exhaled gases that can be used to look for neoplasms in the lung, condensates that can be used to look for specific types of pulmonary function abnormalities, and as I have already mentioned, that pretty much crossed the spectrum in terms of individuals touching on those things. The entire group thought that there was a definite need for better application of spirometry, and even though spirometry has been the wherewithal of the pulmonary function lab for the last couple of 100 years, we can do a better job of making sure that it's used appropriately and that it will be important in the future. All of these papers were published in the January 2012 issue of Respiratory Care, and I would encourage you to make use of the online availability of these papers. If any of these particular topics caused you to have a question or are related to things that are pertinent to your day-to-day operations of your laboratory, you can find the complete papers in this particular issue of the journal, and I would encourage you to go and find the paper that meets your needs. The references are very good for all of these papers, and the journal includes the discussion that went on among the participants, and in many cases this was a quite lively discussion, and there's probably as much to be learned from the participants discussing some of these topics as there was from the presentations themselves. So I'm going to stop at this point, and if there are questions, if we have time, I'd be happy to try and answer those.
Greg, thank you so much. This was fantastic, and there's been an amazing amount of discussion. What I'd like to ask you to do, Greg, is to hang on for just a second. I'm going to end this, and then as the survey is up, have you answer some questions, as there are some folks who need to scoot out of here due to time. So if you're watching this as a live presentation, please stay with us for a second for instructions on how to obtain your CRCE. If you're watching this program as an archive, this concludes our presentation.